All right, Lauren Ballinger. Dr. Lauren Ballinger is a board-certified pediatric dentist and a certified specialist in orofacial myology. After 15 years of practicing restorative pediatric dentistry and interceptive orthodontics, she experienced her own aha moment that changed the focus of her personal and professional life forever. Inspired by her own children, Dr. Lauren began a pilgrimage of deeper learning and understanding to be the change for her children and for all of the children that needed her help. Dr. Lauren recently founded Good to Grow Pediatric Dental Wellness. I love that name, by the way.
Thank you.
Airway Growth and Sleep Solutions and the Nurture Frenectomy Center, creating an answer to her calling in unique pediatric practice model solely focused on addressing the root causes of suboptimal function, growth, and development.
That's a lot of words.
And I'm still, I mean, I'm better from COVID, but sometimes it makes me want to cough. But anyways, so today we're going to be talking a little bit about everything. Our big topic was be the change. So thank you to Anne, who is our editor at Airway Circle. She has put some wonderful questions together. And also Dr. Lauren Ballinger let us take some questions from the wonderful Endeavor group. They have some Q&As. She sent those over to us also that we're going to be using. But if you guys have any questions, please let us know on Facebook. I have my phone with me so I can read whoever's live on Facebook, and also on Clubhouse or over here on Zoom. You guys can just put it right on the chat and we will read them to you. So thank you so much.
Talk a little bit about doing a presentation versus just sort of talking in Q&A. It happens to be that I have a real short presentation that I'm giving a collaborative cures. Like if there's absolutely no questions, I could go into that. But I usually find that whenever we all get together, right, like this, sometimes I know I learn a little bit more sometimes in a group setting, just talking and sort of riffing it out. So however you guys want to do it is great.
Definitely. Would you like to share something? It's up to you.
Not necessarily. Unless everybody, so this presentation is really what I would be giving at Collaborative Cures. I don't know how many people here are going to be there. So
I'll be there. Everybody lift your hand up. Tell us on the
chat.
I
don't want to give it if everybody's going to see it again.
Exactly. It would have to be after. We have to bring it back after.
Okay. Right. So, really what this is, it's going to be a short, I'm assuming most people know who Bill Hang is, the orthodontist, right? So through our Endeavor group, we wanted to do a shorter presentation, and really what the Endeavor group is, which is, a year and a half ago when COVID started and we all weren't in work, it was interesting. Kevin Boyd, I'm sure you guys know who Dr. Kevin Boyd is. I think has he been on your?
He has. He was on my birthday. Right. He's on my birthday gift.
Well, no one, that's like the best birthday present ever. We actually both had the same thought simultaneously when we were sitting home, which was, one of the silver linings with COVID was that it at least was getting people's attention about breathing. And, a lot of the, the general public might not have realized this, but a lot of the comorbidities, the people who get sicker with COVID, happen to be a lot of the same comorbidities that go along with sleep, breathing issues like OSA. So it was really strange that we called each other at the same time, and we were having the same thought about, this is really a chance for us to maybe get attention of the public in a little bit of a different way because people are aware. So before you knew it, we sort of gathered a group of, to be honest, most of them are my mentors. The fact that we meet once a week, and we've done so for almost 18 months now without missing a Monday, is sometimes a dream come true. I pinch myself because I can't believe, we've become friends, but like I said, most of these people have really impacted me hugely professionally. So fast forward, we are going to be giving sort of, I think there's 6 of us or 7 of us giving quick 18-minute presentations based off of a woman who's an activist that Bill knows. It'll be the first time I meet her, but apparently she did work. You guys are all probably too young on this to remember even Ronald Reagan and the Just Say No to Drugs campaign. But, you know, she does a lot of government advocacy and philanthropy. So she has a daughter who's in her early 20s who, you know, just was misdiagnosed and led down the wrong path before she saw Bill hang, and just has all these, you know, lifelong issues that we all know about when kids grow into adults with airway issues. So she's giving, I haven't heard it yet, but a very inspirational speech, and then we're all kind of going after pretty quickly, right? And my task that was given to me by Bill Hang was to sort of talk in 18 minutes, which is not easy, about my aha moment with my own children, and then also how that left me to sort of realize that I was an airway patient too. You know, a lot of times I think parents, when I see parents, you know, one of the ways that they start recognizing their child's potential for illness is because they start recognizing some of the signs that I might be asking about with their kids. My sort of aha moment for me personally, I sort of backed into it because it totally made sense for me for kids. And then the more I started learning and, you know, sitting in, oh my gosh, I see Marilyn Lobo's name here. Marilyn Lobo and I did our residency together.
Oh my gosh, how exciting.
And we're separated by oceans. She's in Perth, Australia. Oh my gosh, I'm so happy she's here. Anyway, she's one of my besties. Yeah, so I sort of backed into it. And it was sort of another aha moment for me, like, oh, wait a minute, like, you know, my chronic headaches and sort of living in this, which I think a lot of us that are probably on this right now live in this highly sympathetic, cortisol ridden state. You know, I don't know if it's a personality disorder of the kind of, you know, I think it's partly our physiology and maybe partly our mentality. I don't know. But I started learning a lot about myself and some pretty significant things. I mean, you know, it's not about me, but, you know, when I started scanning myself, I probably have one of the smallest airways and spaces you have ever seen. And we have, I know, all seen a lot. And yeah, I'm a candidate myself for double jaw surgery, and I have some condylar resorption. I mean, it's really amazing. And what's amazing for me about that is how some adults can compensate a little bit better than others, but it's always going to come and get you at the end. Like, it's always knocking on the back door, right? Like, you think you might be overcoming and compensating, but at some point your body and your physiology catches up with you. So that's been sort of how I learned about it. And I think it's interesting because when I speak as a pediatric dentist to a lot of general dentists, they're sort of learning about what you can do on the front end because they're bombarded with all these adults like me of how are you going to unwind this, which, you know, I don't necessarily think it is rewindable. I think, you know, it's trying to find the best symptomatic relief to, you know, even double jaw surgery and myofunctional therapy, all the best modalities that you can do, the best is to catch it earlier, right? So you can help kids, you know, not grow into their disease, but grow out of it. So, right. Okay, so that's a little history of me.
Perfect. We got 11 people on Facebook. We have a great crowd on Clubhouse and 13 people here, and it's going up over there because I just did some shares. That's why I was looking away for a second.
Oh, great. No.
We have so many amazing questions. Do you do orthotropics at all?
I do.
Ah.
Yes, that's how I met Bill.
Oh, yeah. All right. So what is the earliest age you've treated a child with orthotropics?
That's a great question. So let me answer it indirectly like a politician. You know, for those of you who know about orthotropics, there's sort of this sweet spot, right? You want to usually be in the early-ish mixed dentition. You can treat in the primary dentition. But, you know, you want to be in the early or mixed dentition when you have your front, upper incisors because you want to flare those out. Okay, so that could be anywhere from 6, 7 to 8. What Bill and Hang and I have been talking about a lot, and actually what myself and two other pediatric dentists, Loria Nahadas and Carla Damon, who Loria is also a co-resident with Marilyn and I, and she met a really fantastic Airway pediatric dentist in Texas. So the three of us have been meeting with Bill once a month as he's developing, guys, this is so exciting, hit a newer course and to talk about pre-orthotropics, because we believe that if you start early enough, okay, and I have some cases, and I can even show you guys some cases later if we have some time. I have a case in my presentation where I started with a little boy who's dentally delayed. He's just 3. I put a hang type expander, which is sort of like a bioblock stage 1, on his D's, on his first primary molars, because he was ready and his parents were ready. So, the premise really is that orthotropics, surgery without a knife to get those jaws forward. But if you capture that growth early, which is really that 3 to 5, can get that, you may not need orthotropics. And one of the things that Bill, who was trained by John Mew, and all of us little of his disciples will all agree, is that orthotropics is very difficult. Okay, my daughter went through orthotropics twice. She started with Barry Raphael, and I took over the second half. Those were my first cases. I know we've all treated our own kids, and it's probably the hardest patients we have for so many reasons. And I have about, I have over a dozen other ones that I've done, which doesn't sound like a lot, but these cases just drag on forever, and they are highly compliance driven. If we can affect change and correct that growth and get them on the right track, and then support it with good function and breathing, then we don't need orthotropics. So that's my answer to that. So, the kids that you treat in orthotropics have to be, it's not so much age, but you need, good D and E, roots in there. You want your laterals and incisors in there. And again, so that can be anywhere from 6 to, for a late developer, 9. But really the thing to think about is when Bill comes with this course, if we can, and that's what I really like talking about, let's get really brave and get in there at 3 and, get going and get that growth right. So we might not need it.
Sorry, I muted myself and forgot about it.
Yeah.
So it's a 2-part question. How do you incorporate myofunctional therapy into your practice? And what results have you seen with the addition of myofunctional therapy in combination with orthotropics? Great
question. Okay. So I believe that none of this is really possible. You can be the best dentist, the best orthodontist, the best, whatever it is, and, use your appliances brilliantly and get the structure completely right. If you don't support it with being able to establish nasal breathing, have a proper tongue position with your lips closed, the kids are going to grow out of it. So they have to be both. It's crucial, not just for orthotropics, for anything that we're doing, because I know I'm talking to, what is that thing? I'm talking to the group that already knows this, the tongue is the scaffold for everything else, but it's true. I've seen kids, I've done the best work I can. They kind of fall off their myofunctionals, or they're not treating their allergies. This is usually an underlying thing that we come back to, is that if your allergies are not diagnosed and treated, really sometimes like paid attention to and dealt with on a daily basis, the mouth breathing is going to come back, and these kids start like growing out of what you just did. So you have to have the myofunctional. The way that I've incorporated it, and it's really important for me to say, one of the things I've come to is that, like, I am not a believer in like this person's appliance is perfect, this like system is perfect. Like, I did drink the Kool-Aid. I've made so many mistakes, so I try to share mistakes with people so they don't. So for instance, I'm a certified MyoBrace provider. I love MyoBrace. When I first started doing it 6 years ago, I thought it cured everything. I drank that Kool-Aid, right? Now, you make some mistakes. The way I describe MyoBrace or Healthy Start or any of those, which I think are all very effective, is is it's a tool in your toolbox. And one of the things that I got out of saying was, I used to use MyoBrace, say, okay, well, if we do this early enough, their tagline is straight teeth without braces. All right. What I've learned from experience and just also my mentors and just doing hundreds and hundreds of cases is that even if you do an infant frenectomy, these kids are already born, 5 months behind because their facial respiratory complex started developing in utero. So yes, you might release the tongue. Yes, you might get optimal breastfeeding, but their structures are too small. And more times than not, the function isn't enough to catch up to where they should be. So myofunctional therapy, we just say for patients, just so they get it, is, and I'll tell you how we do it in my office. When you're seeing us for MyoBrace or for myofunctional therapy, which we also do separately, it's to treat the muscles. If we're doing the ortho, it's to treat the bones, so that they're complementary. And I think you need both. So I started down the MyoBrace path because I have an incredible team of women that work with me who are so smart and motivated and just like incredible learners. They got smarter than me really quickly. One of my assistants would come up to me and be like, well, if I do this, am I getting the longitudinal fibers or and I was like, what are you talking? Like I knew, but she was coming, because I'm technically overseeing her. And I was just like, all right. So I decided to get my certification in oral facial myology because I just wanted the bigger picture. And I think what's great about that is then that allows you a little bit to get out of the box of, just what MyoBrace is telling you, or just what, or, that you can start to sort of pick and choose and start to realize that, this child might do well with a trainer. This child might do really well with some exercises without the trainer. It just gives you a little bit more flexibility. So every person, every treatment plan that we do, the way we incorporate it is I incorporate it as part of the fee or what we're doing in our program. I don't anymore. I used to say, if you do this, like for myofunctional therapy, then you might get out of this. Mm-hmm. I've learned that doesn't work. Mm-hmm. So it's an inclusive fee because I feel like, even though I'm a dentist first, not a myofunctional therapist, so it's, I don't feel like they're getting 2 for 1. They're getting something additional. And there's always going to be cases that, just like any other specialty, where they might be better with a oral myofunctional therapist. It's not in a dental office, right? Like we can get through most things, but we're always going to get stuck and may need to look to another professional. Also, what I found is I tell them it's all on you. It's compliance based. We can offer it. Like I know I can get you there with structure, but it's really up to the parents and kids to get themselves there with, it's a huge commitment. All of us know that. So it's offered at every part of what we do.
I love it. Mm-hmm. Can you take us through the process that you use to determine which appliance is appropriate for which child? Thank you, Anne. Anne wrote these questions. And
okay,
fabulous.
Great question. All right, so let me go back to what I just said first. So a lot of people will ask, what appliance did you use, right? Like, what do you like? So what I'm fortunate about, when I came into this, I had a very heavy ortho background, not necessarily from residency, but the first 15 years that I was working, I worked in a practice. It was actually my family practice, where pediatric dentists, they had been doing early phase 1, phase 2 orthodontics for 35 years. So I had to learn up quick. So I had a lot of bracketing and understanding. Okay. And I'm saying that because it's not necessarily, do you use a BioBlock? Do you use a Schwartz? Do you use all the different things? It's understanding what your goals are, right? And the limitations of just expansion. So, or not. So I have used everything. My favorite usually is the hang expander, which is really like a BioBlock stage 1. It looks like a regular acrylic horn. What makes it a little bit different why it's a hang is because it has clasps on it that allows kids to eat with it. So it's removable, but they can eat, I tell them they have to wear it 23 hours and 55 minutes. Okay. Mm-hmm. There are some kids, and I've been doing a lot more experimentation and asking, And I sort of got this from Kevin Boyd about, the way he asked it is he'll ask the mom, is your child a rule follower or not? You probably talked about that, right? To decide whether they're going to have a removable or a fix.
Mm-hmm.
And what's kind of cool is that you can have that same expander that I just talked about that's a removable, ask for like a little bit of occlusal acrylic. I mean, sometimes you need more occlusal acrylic to open up the vertical, but I'm just talking about like a little bit. So if you give a kid a chance to see how they're doing and they're not working, you can cement it in. So, it doesn't become an issue. The last 6 months, I've been playing with a couple other more cemented appliances, the ones that look like, a traditional expander with the metal key, and then they're acrylic more and they look a little bit different. So really what I'm looking for is, I know that every child can handle an expander. Okay. I can, like I said, we have some time, we can do it. Kids are like dogs and they smell fear, right? If you have the confidence to believe that they can get through this, I guarantee you'll get through this. So you have to convince yourself, and then you have to convince the parents. So, the children aren't feeding off of them. But, I treat kids 3 to teenagers. I wish I didn't have to treat teenagers, because to me, they're like treating an adult patient, right? So if I could just limit my practice to, up to 8, I really would. But the problem is there's no one else that's gonna, when these older kids walk in, who else is gonna help them without hurting them? So I look at,
Love that.
yeah.
I love you
Yeah.
said that. Help them without hurting them. I'm gonna write that down.
Okay. Yeah. So,
Wow.
I'm always like, okay, I'll do it, but they're hard. You guys who treat adults, it's so hard. It's really hard. So yeah, really, I mean, really any expander will work. Sometimes you need to open the bite up. I use Hang's Lab a lot. I like that. His appliances are expensive, but they're excellent. And if you get in contact with him, he will also sort of mentor you through it. Like if you have questions, he'll kind of help you through it. I've been using a little bit of Dynaflex's lab. I really like those. I mean, I've done a little bit of everything. The goal that you have to understand is, what are you trying to do? Do you want to get transverse expansion? And really, you can get that in many ways. A quote that I love, again, from Dr. Hang is though you can't always expand your way out of an AP problem. You can't treat an AP problem with a transverse solution. So a lot of these kids, even ones that that we call class 3, but they're really maxillary hypoplastic, a lot of kids need reverse pole headgear as well. So especially when you're doing that early, it's great. So I hope that answered your question, but it can be fixed. It can be removable. I know a lot of people get, well, do I do a half a turn every day or a quarter turn? Look,
It depends on the.
Okay, I'm going to just boil it down here. I mean, really, you can't, you're safe with semi-rapid. All right. So in general, how I started is with the appliances that I get, the screws for every turn, it's like a quarter turn, it's a quarter of a millimeter. So 4 turns are a millimeter. So I start most kids off with a quarter turn, which is a quarter of a millimeter every other day. So that means by 4 turns, it's a millimeter. Okay. And that usually goes along really, really well. I do tell kids and parents, especially older ones, to listen to their body if they just feel, because ideally every child going through structural correction should be having some sort of body support work, right? Because every time you're changing something, even though you're changing it for the good, everything else is falling off. Okay. But not everybody gets to do that. So I do believe that sometimes we do create some craniofacial fascial stresses. Mm-hmm. Of course we do. Sometimes after you get the best massage in the world, you feel beat up the next day, right? So, yeah, I mean, a lot of times it feels like you're taking 2 steps back to get forward, but getting these kids out of distress as early as possible is important. So that means that we're doing a millimeter, like maybe every week and a half. Mm-hmm. So, but sometimes I'll tell them to slow it down to like twice a week. I never do it faster than that. If I suspect that a kid is taking it out, which you can tell because it gets ahead of itself, and even though if they're saying, no, I'm doing everything right. And you just know sometimes I'll go down to once a week. But in general, it's, so if we did 1, 2, if you're viewing like 2 and then 3 turns, yeah, so it's like 1.5 millimeters every 2 weeks.
And you do that with all the expanders, pretty much. It doesn't matter which expander, that's the rate.
Yeah, I mean, right, they all might have a little bit of different thing, but
turn,
I'm just, I hate to say this, and we talk about this in the endeavor because we don't want to be flippant or feel dangerous, right? But when you're working with kids this young, you really can't hurt them. Now, I'm not saying to be out, go out and be a cowboy. You need to know what you're doing, but you can't. They're like malleable, and their body wants to get better. So, oh,
I love it.
Yeah, it seems to work. And I do lower expansion. You have to do lower expansion. And, really what the lower expansion is the uprighting. But it's amazing. Like, you sometimes just can't believe you have to do it. So usually with the little kids, because they're so little and they're already orally crowded, putting all this stuff in their mouth. I usually go through, especially with these little kids, 1 full round of an upper expander. And these expanders are so small that like sometimes you only have 5 millimeters in the first screw. So they're going to get through that really fast. They get used to it. And then the second expander, we may add in a lower one. It's just because you can catch up with the lower. You don't need with these lower kids to like throw everything at them in the kitchen sink, because the upper one needs to stay in for a few months after we get them there anyway, so you can catch up on the bottom. But doing lower expansion is very important. I do mostly fixed on the lower. For some older kids, I'm experimenting a little bit more with the removable Schwartz for very compliant kids or kids where I need to open the bite, and that's working out really well. That's
fantastic. We have 2 questions. Dr. Tuesday says, up to what age can one use a fixed expander?
Boy, that's a great question. And I don't know. One of the things that's on my bucket list of learning is, TAD supported maxillary expansion, where you're getting less tipping and more skeletal. The only reason why I don't do that yet is because, as you guys know, we're all CE junkies, and there's only so many courses and things you can learn while still trying to work and keep the lights on, right?
Yes.
So, and because I like to focus on lower kids, I do expansion because that particular tool is not in my toolbox. I do use expanders in teenagers, like the ones that I'm talking about. I do tend to go a little bit slower with the rate. Like usually I'll start them at like twice a week, because I want to try to avoid tipping, a little bit more. And I'm getting very good arch forms, because, I don't know if I'm getting that sort of nasal cavity expansion that I'm getting in the young kids, or I get with TAD supported implants, but I'm definitely getting more oral volume. I did expansion on myself under, again, like, I know we all do too much stuff with ourselves, but Hang was watching me, and I was really, really narrow. I was under 30 intermaxillary width, and just with expansion, yeah, you guys, that's a whole other story. You don't want to see my nightmare.
I'm at 31.
Oh, okay. Yeah. I know, it's like, instead of like talking about like our height or anything, we're talking about, it's like,
what's your molar to molar?
I know things have like our standards of attractiveness and beauty have like, it's like all different, right? It's like, do you have spaces? Because spaces are like in, right? So, but I got to about 37. Okay. Wow. And without a lot of tooth tipping. Now, it's funny, since I took it out, because it really, we wanted to see if it would kind of get me out of surgery, and it wasn't. And I'll tell you, I've relapsed a little bit because, at night I don't breathe well through my, it was more an experience. It was great for me to wear because I got used to it. And I used to say I had a top and a bottom. And when the kids would look at me, it would be really fun to say, hey, I have it in too. So I do think you can get some expansion. I'm not like Dr. Yoon, where, they're doing all the studies about what, or Mariana Evans, where they're really looking at the, following up the sutural expansion in the nose. My guess is that you get better expansion if you're doing TAD supported. But again, I've used them in teenagers because I figure again, because I feel confident enough that I'm not going to tip the teeth or hurt them, that I'm helping them. As long as you feel in your wheelhouse that you can do something that's beneficial and not hurt them, I think it's worth going for it.
We have a question on Facebook by Emily, and she says, is flaring out, this is from whenever you said in the beginning, is flaring out of the incisors the best way to unlock the mandible?
Yeah, so when you're doing orthotropics, for those of you who have done or seen orthotropics, it is the scariest thing you have ever seen. Yes, and you're taking up some of your follow-up films, and those teeth are just out there, and the roots just look like they're out here, and that's why case selection is so important. Not so much that you're going to do something wrong, but that if your patient jumps ship in the middle of your treatment and goes to the orthodontist down the street, they're going to see that and just totally freak out. Okay, right. So yeah, so right, we know that the maxilla really is the arch that is causing us problems, right? Like everything else is dependent on that maxilla. And the way I explain it to patients is like, if you have a box, like a shoe box, right? That top that goes on it is going to constrict the lower part. So, when your incisors are that deep bite is like this, even if you open it up, right, you're still constricted. So by flaring these out and opening the bite and working on tongue posture, you can get that lower mandible to come in. That's something, that's not just a principle in orthotropics. What's really cool is that if you learn a little bit about orthotropics, you can do a little bit of what's called orthotropic light. I kind of made that up, and that you can still use an expansor or some sort of advancing appliance. Okay, you're not going crazy where you're going to do the positioner, but when you're working up these cases, what we all start to see is that these canines are on the wrong path, and they're going to be impacted or start coming in ectopically. So flaring out those incisors, opening up the bite while getting your transverse allows that lower jaw to come in, but then it really starts, because when your canines are impacted, it's not really a transverse problem, it's a AP problem, right? It's almost like the incisors haven't gotten the message. It's like they are in the right place, your maxilla is not.
It's not. I love that.
Right,
yeah.
Right. So it's like you have to figure out how you're going to bring, and if and when I'm talking about the maxilla, the premaxilla, how are you going to bring those sort of 4 teeth in front? So that's what I do a lot, even if I'm not doing orthotropics. I do a little flaring, expansion, bring them out, and then I consolidate those 4 teeth with like utility arch mechanics with some braces, and then that's like, that to me is finishing the case. When you get all 4 of those teeth in alignment, open the bite, the jaw can come forward, you're doing your myofunctional therapy, and then you have them maybe in a Holly retainer that could be for years, because they're not going to get their canines till they're 12. I finish with a lot of extra space where those C and H are, a lot. So it almost looks like you could fit another tooth between the lateral incisors and the primary canines, but then over the year, they just right into place. And I feel like, if from a dental goal for me, like we have airway goals and function goals, which are incredibly important, from like the plain old dentist in me, the tooth thing, if I'm like, all right, if I can make space for those canines and get them in, that's a huge accomplishment. So that's another part of starting early. So you're right. So flaring those teeth are also helping to consolidate them forward so those canines can come in.
Beautiful. Doris is saying, are you expanding the bone when working slowly? At what age do you get tipping rather than skeletal expansion?
Yeah, I have to be honest, I don't know exactly. And I think that our histology, our histology, we know that, growth is pretty much done by 12, right? But I think all of our histology is a little bit different. Like Dr. Ramirez believes, for those of you who heard him speak, and I love him,
He's
he
great.
starts talking about, I have a 71-year-old baby, he has the greatest accent, that's what he says. So I treat my 71-year-old baby with expansion. I mean, he's also, what does he have, like his degree in embryology? Like he really understands bone. right? And he believes, and it, has great slides and research. He's done the research that says that yes, you can get that, right? And then there's some research that says, no, you can't, right? No, you can't. You can just get tipping. And I think because this isn't new. I mean, the art people have been doing expansion, for centuries, the last, in the 1800s, there's literature about this, but in terms of asking for validated evidence support, it's not all there yet, so I hate to tell you that it's a lot of careful experimentation and talking to other providers and seeing what you're getting. But I have found that by using an acrylic borne expander, so you have some acrylic in the palate, right? That I'm sure I'm not getting just skeletal expansion. I'm sure I'm getting some tipping. But when I, do my follow-up records, I mean, the teeth are not, it looks
Exactly.
It looks good. It's better.
Yes.
It's better. I've also learned to temper myself, guys, with, as dentists, we are so, oh my gosh, and hygienists, even worse than dentists. We are so focused on details and measurements and stuff. I think that once we start giving ourselves a break about, can we make our patients better and not perfect? There is no perfect in human beings, and whatever we're doing, we're also not living in a hermetically sealed bubble where there's not environmental stress, all the other stressors. What can we do to help make these patients even better? And then you start feeling a little less frustrated with just the barriers of life, right? So it's always worth trying.
That is so true. Let's see another question that I have here. You already talked about fixed and removable. How is your Nurture Frenectomy Center set up, and what disciplines do you work with? Are they on site?
Great question. So when I set up this practice about 1.5 years ago, right during COVID, because I figured, why not?
Wow.
Why not just go?
Why not start a new business?
I'll never forget my husband, who's a dentist too. We're all out of work, right? And we were taking a walk. Oh, Anna was in a front end car accident on March 9th. Oh. And we were taking a walk because, I was kind of rehabbing. And I said, wow, I don't think I'm going to go back to my old job. And he's like, what? Boyd, what? I'm like, yeah, I don't think I can do it. I think this is the time. Like you have like a near death experience. You're like, yeah, I'm done. Right. Wow. So, yeah, it's been the best thing I've done, but it's been a little bumpy, just like how everything has been from COVID, not because of patients, just because of everything that we're dealing with. So one of the things that I did is I set up, the reason why I have 2 practices is because I want to be able to take Medicaid for frenectomies, for infant frenectomies. Mm-hmm. So as a pediatric dentist, I feel like it's very important to, provide to the underserved populations. Dropping Medicaid, or what we have, Mass Health, from my general patient population was very difficult for me, because I feel like, that's, as a pediatric dentist, you definitely have a sort of a community health mind. Mm-hmm. But I stopped doing restorative dentistry completely. And, but I wanted to make sure for a newborn infant, a lot of times these babies aren't even on anybody's insurance, that we could open it up. So I have 2 PCs. That way, one is completely fee for service, and then the other one, we're accepting insurance. So this is what's really cool. You remember I told you guys I have like the best team ever? Yes. So my assistant, believe it or not, and I say that because I think assistants a lot of times are really undervalued. One of the things I've learned is not all women have the opportunity to take the course in life that we had, to get, not everybody is, has the opportunity to go to college and then grad school after. Not everybody has the opportunity to go to hygiene school. It does not mean that you don't have a brilliant mind if somebody gives you the opportunity or the curiosity about it. So I just have young women who are just incredibly brilliant. One of them decided, she got just really turned on by what I was doing. She went and got her certification. She's a CLC. And when she went to do her certification, she was the only person sitting in her class that wasn't an RDH or have her master's or wasn't a physician's assistant or an ICU nurse, and she nailed it. So, and and she will work one day to become an IBCLC, but to be an IBCLC, that is like a upper level master's degree, right?
Yes.
So the way we work it is, so she is always on site with me, and it has changed everything because she is able to do all the workup, all the intake, all the nurturing that I like to do, but I don't have time to do while I'm trying to run a business. She'll get them all worked up, all the assessment, look at the breastfeeding, do the weighted feeds, all that stuff. I come in, we do our diagnosis, when we do the treatment, then she follows up with them right after. She's able to help them with positioning. We see them the day after, we see them 5 days after that, then we see them 7 days after that, and another 7 days. And then she also makes sure that she's collaborating with the other IBC, whoever else they're working with. She helps get them into body work. So she's coordinating all that. It is a gift. I would really recommend any of you who are doing infant frenectomies. I don't know what the laws are like Maryland and in Australia, but you can get your CLC. You don't have to have an RDH or a master's degree or a doctorate degree. And if you have a team member who is a mom and might have gone through any of this and has an interest, it just changes everything. She also is now almost finished with, she's also getting her massage therapy license. Okay. So then she's going to, then she's doing some mentoring and some other work with some craniofacial massage. So she's working to do that to help also with some body work with the babies. And yes, having it on site is like a dream come true.
That's amazing. Dr. Martha Cortez is listening on Clubhouse. She's asking,
we haven't met, but I know about her, right?
Yeah, she's fantastic. What is a CLC certification? That's a certified lactation consultant, right?
Yes. So
Perfect.
when you see
certified?
lactation consultants, there's like LCs, okay, and I'm sure they're very good, but for those who are like picky about certification, being a lactation consultant is more, it's something more that you can. I don't want to say weekend warrior. I don't mean it like that, but I think there's less of a licensing, there's less of a certification. Okay. A CLC is one step up. It's a certified lactation consultant. And they have to have a certain amount of hours in the classroom and cases to get your certification. And then an IBCLC, it's that plus, IBCLCs are usually, they've been ICU nurses. They've been, they are incredible. And there's not enough IBCLCs, just like there's not enough myofunctional therapists to serve all of us. There's just not. So how can we sort of like make a spider web of team members, right? So a CLC, she has 2 IBCLC mentors that are in the area who, and their group work with a whole bunch of CLCs that she can call if she's stuck. Or, you know what I mean? So it's a great collaboration. So it's a certified lactation consultant. And if anyone is interested in it, the way Taryn brought it to me is she just searched, how do I become a certified lactation consultant? And, in each state, they're running like some certification courses. But hey, look, she nailed it. She said she was so intimidated at first, and then she nailed it.
That's amazing. I want to so bad to get my IBCLC. And then I heard that in Georgia, you have to retake your boards every 10 years.
Yeah, listen, what? IBCLC is no joke.
Retake your boards? Are you kidding me? Nobody else has to retake their boards.
So do a CLC course.
Yeah.
I know we all want that IBCLC. That's just like great. It's just amazing, but you can do so much. Oh my gosh, her knowledge, like what she's learned about, things that she can just help them in different ways that, that I'm interested in, but as a dentist or a hygienist, you may not have time. It's made all the difference in the world.
Oh, there goes. All MDS have to retake boards every 10 years. I had no idea. That's insane.
All what?
MDS. What are MDS, Dr. Martha? All MDs, maybe she means MDs. All MDs have to retake their board.
Well, I know like Maryland and I, we have to, oh, again, no, it must be
Yeah,
something
she's
about that.
saying yes.
We have to retake our written boards, our pediatric written boards every 10 years.
Gosh.
Yeah.
Oh, that's something. All right, Sarah Beach. Hello, Sarah Beach. She's on Facebook Live and she's saying, love, love, love your approach to practicing team dentistry. Thank you for highlighting the importance of the team supporting what you do. It really changes everything.
Okay. Yeah. There is absolutely no way that I could have for me, for my day, that I could even come into work and be happy and function if I didn't have the team. But the results that we're getting is from the team. It is absolutely, and I look at them as my partners, because we are partners in crime. We are each putting our certain little spin on it. Somebody asked before, what kind of results do we get from myofunctional therapy? So I spoke about Tara, and Dakota is just such a mastermind, and she really runs all my myofunctional therapy. We all do have our certification from MRC as, myofunctional, whatever, it's a myofunctional certified myofunctional therapist, whatever. I mean, people get all mixed up, but she really knows what she's doing. She's the one that she closes open bites for me. She's the one her work is incredible, and she is sort of running her own thing. Taryn's running her own thing, and at the same time, they're sort of jumping in to help me. They have a lot of orthodontic training because they followed me from my other practice, but the only way that we are able to function and provide the kind of care we do is because of the team. Without a doubt.
I love it. We have one last question before we call the night. And by the way, if you guys want to rewatch this, we will have it available on our airwaycircle.com page. So for members, if you are a paying member, you have access to all of our recorded clubhouses and all of our recorded Facebook Lives. The first Facebook Lives that we had done, the first 6 months, they're open to the public. And now we just started keeping it for our members whenever we started our membership. So join us. Also, we just put a video out there today from Marielle Bussi, the SLP from Brazil, who's going to be doing an incredible class on sleep disorder breathing and myofunctional therapy. How do we treat as myofunctional therapists patients who have sleep issues? What are you looking at? What are you doing? What kind of exercise are you choosing? It's going to be very in-depth. And everybody always asks me, what are the exercises they do in Brazil? Because those work.
Yeah.
Well, you're going to find out.
Brazil is way ahead of the curve, always, right?
Yeah. Yes. So you're going to find out October 2nd. Join us. We're so excited to have her. So our last question. And then also I would like for you to tell us a little bit how we can find you if you're going to be patients, but how can we best support parents pre and post frenectomy?
That's a great question. So I think it's nurturing, loving them. Okay. But I think, some of the mistakes that I have made is, because we're really nice people in general, and we want to always make everything easy and not hurt. But I think being very honest about expectations that for me, and I tell patients this too, like, you could come walk off the street in my practice, and because they were referred by someone, so and so, and they say, I need a release. In my practice, that's not going to happen unless we're approaching it comprehensively. Like, if you just want to release, you got to explain why, right? So you really do have to explain in a language that they can understand that, the frenum is just the tip of the iceberg. And there's a lot of other things that we have to work out for. I mean, there's kids, there's babies that they need body work before. And why can't we just do this? Because it doesn't work. So really sticking to what you know inside is sort of and not getting talked in to, because we know parents want these quick relief, and we know, those of us who are parents, what a pain in the butt it is to take time off of work and school for appointments, and how busy life is after, and doing all these other exercises. So especially like for an older kid, I will say, this might not be a good time. You just had an infant, and your child just started 3rd grade and you're going to have this whole program where you have to do this 6 times, it's not the right time. If let's find a time that's really going to work where you're going to focus on this. So setting expectations, making sure that like before, when you do pre-functional myofunction, like pre-release myofunctional therapy or stretches before, that you give it to them as pre-homework and check up on them. Like have them come into your office and say, show me what you're doing. So that they're doing it right. Or, the kids are doing the myo. It's not just, you guys know, it's not just tongue clicks. You have to be doing it right. So really spending time on the front end, getting prepared and not letting yourself get sort of heart tugged into just doing it because you want to help. You are not helping as much as you could if you're not sticking to their guns. And then that means that post-operative care, you've already prepared them. It's about going in prepared. So yes, within the first 10 days of life, if a child is struggling, you need to get in there and do it right away, and help hold their hand to support them. After that, if a baby isn't in distress, like around 3 or 4 months, when the milk, when the hormones stop pumping and it's more of a supply and demand, these babies really do benefit from some body work before, and the baby is not in distress. So we have time. Then that goes to older kids. We might see kids, they're like so tongue-tied. They've been like this for 6 years. We've already had 6 years behind them. We don't have to rush right this second. We want to make sure that everybody is prepared going into this. And even from, talking, like really spending a lot of time about what's your post-operative pain management strategy, making sure you have all this together so there's no surprises for them and there's no calls for you for, where everybody is all flustered, especially when you first start doing it, because you're second guessing yourself anyway, and so the more prepared, because we all second guess ourselves, right? But the more prepared you are, the less sort of things in the gray area. So just really sticking to your guns about what we know about the importance of prep work. And if you've usually done the prep work, then the post work, they're already set up for it. Does that help a little?
Definitely. That makes so much sense. Thank you so much, Dr. Ballinger.
Oh, I'd love to come back. I'd love to, I'd be happy to show that presentation that I'm giving, because I really like it. And yeah, I'd be happy to talk about appliances or show a little bit more of the younger kids, because I have some really fun young kids that I'm working with who are just, it's just, guys, there's nothing more fun than treating 3 or 4 year olds. There's now, I know there's some general dentists that do adults who are probably like cringing. And I feel the same way about you. Like I couldn't treat an adult airway patient for any, like I couldn't, like, I'm so amazed about what you guys do. But if you like kids at all, it's really worth sort of getting out of your comfort zone and realizing that they are in so many ways so much easier to get through this than an adult, and so quickly rewarding. They can do it. They love it. I will take a 3-year-old over an 8, 9, 10-year-old any day.
Fantastic.
Although I like those kids too.
Yes. If you guys would like to have Dr. Ballinger back, please give us some little hearts on Facebook and share this live. I'm going to leave it open for about 24 hours. If you guys.
Yeah, so yeah, I'm a little bit in a silent lurker part because I haven't opened my new office yet, but you can find me on my office email. Should I put it in the chat?
Yes. Okay. And I'll do it over here.
Okay.
I'll
So
share
it's
in our
admin
Facebook group.
Okay, so it's admin at Nurture Grow Dentist. Wait, I spelled it wrong. .com. I do have a Facebook, Nurture Grow Dentist. .com, and I think those on Facebook, I think it's Good to Grow. Perfect. And I think it's the Nurture Frenectomy Center. I do have an Instagram. One of my team members, of course, runs this for me because I'm like right in that age gap where like I get it, but I don't get it.
Yes, I'll make sure that I'll put on our social media. I have tagged you guys on our Instagram, but I will share on.
Yeah, will you please? Because like, yeah, I saw you getting set up on the computer and it was like, oh my gosh, I don't know how you. I'm definitely getting older. Like I can't keep up, so I need I need somebody to help me with it, but I'm out there.
We need you to focus on the Frenectomy,
That's right.
the
You gotta be
extension. We'll
right.
take care of social media for you.
I appreciate that. Okay, I'd love to come back. I think you guys are amazing, Renata. I just am so proud of, impressed of you. Thank you for all you do. And thank you for my cup. I love it. You made my day.
Thank you so much. Next week, guys, on Tuesday, we have Dr. Johal. We're so excited to hear from her. And on Thursday and Friday and Saturday, I think, Angela and I are going to be at the AAPMD. We're super excited. Dr. Ballinger will be there. And we're going to be going live from there. So, awesome. Stay tuned. Check our Instagram. We're going to have live videos here and there for you guys to see what's going on at the AAPMD and who are we meeting in the halls and who are we stopping to ask questions.
Oh my gosh, you're like a real life talk show host. I love it.
In the Airway.
But it's really cool.
Don't talk to me about anything else, but if you're talking about,
I know, I'm like that too. We know what we know. And okay. All right, nice to meet all of you.
Anyways, have a wonderful night, everybody. Thank y'all so much. We'll see y'all later. Bye-bye.